Okay. Good morning. Welcome to Project Echo. Thanks for joining us on this Friday, Good Friday. I'm Will Schmeckley. I'm a project coordinator at the Nebraska Medical Association. We've got cases on starting buprenorphine this morning. From we were going to start with Alex, and then we're going to John will have some as well. A couple of housekeeping things, disclosure relationships. Everyone involved in this project this morning has no financial relationships to disclose. And funding statement, we're a grant-funded project funded by the State Opioid Response Grant. It comes to Nebraska Medical Association by way of Nebraska DHHS. Okay, CME certificate process, same process we used last session. So if you were on that, this won't be any different. If you've missed last session, but you've been here before, it's a little different. Basically, there's just the same survey at the end of the training today. That survey will come in an email. It'll also be in the chat link. The link will also be in the chat towards the end of the session today. Just complete a quick survey, and then I will email you your certificate within a couple of days. So just keep an eye out for that follow-up email from me with your certificate. All right, so since this is our first one in this series, I just like to give a quick intro on what Project ECHO is. ECHO stands for Extension for Community Health Outcomes, and ours is focused on substance use and pain. So we've got a group of 6 experts that provide these trainings, ongoing trainings. We can also make consultations available. Best way to request a consultation is just to get in touch with me. My contact info is there. You've also been getting my emails, so you can reach out to me that way. And then here's where we are. We do these in cycles of 4. So our cycle of 4 for April and May will be these trainings here. Today we've got some case studies. A couple of weeks we've got children and adolescents and substance use. Ed's doing one in May on Kratom and 7-OH, and then Alex is going to finish out the series with a talk on ER collaboration for OUD treatment. All right, I'm going to stop sharing my screen here, and I will let our Echo panel introduce themselves. Um, let's see, Todd, would you like to go first?
Good morning, Todd Stahl. I'm a psychiatrist. Thanks everybody for joining.
Good. And let's see, we're missing a few folks today. So let's see, John, I'll have you go next.
Hi, guys. Good morning. I'm John Massey, and I'm a pain physician.
Thank you. And I think Alex, I will let you introduce yourself and get us started.
Thanks, Will. Morning, everybody. Alex Dworak, family physician. And like Todd said, thank you all for being here. This kind of group wasn't around when I was in training and when I was a young physician. And I am really happy that we can all learn together and be part of the solution instead of part of the problem. Oh, Mary, I just see Mary join. So, Mary, do you introduce yourself real quick, and then we'll get going.
Sure, thanks. Hey, I'm Mary. I'm a nurse practitioner here in the Omaha area and an attorney. There you go.
Okay, let me see if I can share my screen here in a minute. But I'm thinking about several cases that I've had of patients coming in different situations, and I would like to make this a little more interactive. So let me get the chat open, and I'm going to ask people to pipe up with what they would do or if they've had experience with this. So. Um, One of my first patients is a 40-something gay man who is on PrEP for HIV prevention and who has schizoaffective disorder. He's been working with his psychiatrist for quite some time and also has a painful rheumatologic condition and got exposed to some opioids. And that kind of got away from him. Cocaine was more his drug of choice. And he's been discriminated against in healthcare settings too. So that's not great. He eventually gets onto methadone and is in care. He's getting his rheumatologic condition managed. He's seeing a psychiatrist who doesn't want to have much to do with the substance use concerns, which is, not all psychiatrists like the ones in our panel here want to be involved in this. sadly. And he gets up to a pretty high dose of methadone. I think at one point he was on 200 milligrams a day, and he's in recovery and doing fairly well. But he would love to come see you in your community practice instead of having to go to the methadone clinic all the time. So would anybody want to jump in the chat and suggest? So he's again currently at 200 milligrams of methadone a day. Should we just start him on Suboxone, do you think? Or what should we do to try to uh, plan a transition to Suboxone? And I can be quiet as long as I have my protein coffee. So, like, basically, is it a good idea to just jump him over to Suboxone from his current methadone dose, or should we try to come up with a better plan? Yep. Okay. Thank you, John. Yes, I think that that is the recommendation. And so now let me see if I can screen share. So where's my? Okay. So I think let's get that out of there. Move that. Um, so there's this is one of the documents I found, and I can compile these and get them to Will. But again, so what I did was I talked to him and I reassured him, I want you to be safe and healthy. And as long like if I'm helping with that, cool. If you stay at the methadone clinic forever, cool. My view of this is similar to what I tell people about Suboxone generally. If you're on this for the next 6 months and then you're off and you're doing good, awesome, love that. If you're on this for the rest of your life, but you're doing good and you're in recovery, awesome, love that. I have no preconceived agenda here. I just want you to be healthy and just reassure people. So, and what we did was what this document highlights is again try to get lower. And he did pretty well getting gradually down to about 30. And he told the methadone clinic, I'd like to make this switch. And then what you're going to want to do is wait till somebody's in withdrawal and then start. Again, as we know, buprenorphine pharmacologically is a partial agonist, so it has high affinity, so it will glom onto the receptor really hard, but it doesn't stimulate it the same way as a full opioid agonist. And so we have to worry about the precipitated withdrawal. So in this case, we want to get the methadone lower. Methadone has a very long half-life, which is part of why it works for daily maintenance. Um, Although it doesn't work once a day for pain. And so if people have concomitant pain and opioid use disorder, as John can speak to, that again, you can't rely on once a day dosing to adequately treat pain with methadone or with buprenorphine usually. So, um, and again, we got him to around 30, got him off ramped, did a lot of education, and he actually was kind of anxious and wanted to do an office induction, so he came and hung out for a bit. And he's been doing great since then. And he is happy that he can get his care kind of, everything in primary care. We actually have a psychiatrist that we recently hired who's helping with his care, which is he's been very happy about that. To get everything kind of under one roof in the kind of our medical home setting. There's also that element of there's a little bit less stigma. I think by federal law, not only is methadone dispensed in opioid treatment programs, also every methadone treatment program seems like it has to be in a dingy brick building in the downtown, in like a major city downtown or something. And the people only go in and out of a methadone clinic for one reason. So there is inevitably some stigma there. Whereas if somebody's going to their local primary care office, it's like, oh, I'm just going to see my doctor, going to see my provider, because of the way that's located, it's often beneficial for patients, psychological health and well-being, not to have to, to be able to go see their usual team. And also, primary care doctor thinks primary care is good. Shocking. Uh, in primary care, we will be thinking about the whole person. So we've had patients who have gotten their hepatitis C detected and treated. We get them their cancer screenings. We talk about their depression. We get their kids in for well childs. Like I've done vasectomies for some of our patients who came to us for Suboxone services. We'll get them to our midwives for pregnancy care, and a methadone clinic just definitionally won't do any of that. It's very siloed. Whereas if people, most of this audience, I believe, are seeing folks, again, we're just going to have that different perspective and going to be attentive to, other needs or like diabetes care, high blood pressure care, you name it. So yeah, but like I said, primary care doctor thinks primary care is cool. Who would have known? So, um, all right. So again, just you want to try to wean down to around 30, and then it's pretty similar to your usual practices. You can use the clinical opioid withdrawal scale or COWS, and I like to print that and give it to patients so that they can have that at home. They can double check, and also you can document. I proved that they're a moderate withdrawal. We're not just YOLOing this and saying here you go. So okay. Any questions in the chat about that? Let me check real quick. Okay. Well, and then another case that I'm thinking of is actually a couple of patients who have come to us for kratom and 708 recently. And again, Ed's going to talk about that. I have a bunch of material there too, but it's highly potent. It's pharmacologically dirty in the sense that it hits multiple receptors. There's just or noisy maybe would be a way to look at it. Like there's a lot going on with it. So um, for somebody who's on kratom, you can again do the standard approach of trying to help them uh, wean down, or just if they're in withdrawal, go ahead and start it. So one patient I saw recently is in their 30s and is like an artisan where they use their hands a lot, and they develop some pain, probably from overuse tendonitis. And had started, gone to the gas station because every freaking gas station in Nebraska is advertising that they sell kratom, and got on this and was using about 30 grams a day, I think. And this person showed up, and they were talking through stuff. They also have some mental health needs, some ADD, and their psychiatrist had just left or something, so that was up in the air too. But they came in and they were, I'm like, "Are you in withdrawal?" And they're like, "No, I just used and I'm feeling fine." So, has anybody had experience with trying to treat people who are on kratom? And what would you recommend if someone is not in withdrawal in terms of like starting Suboxone? So, and I'll go ahead and drink more protein coffee and let the chat pipe up here. So again, if they're not in withdrawal, should we just give them some Suboxone?
See Dr. Stoll shaking his head yes. Is that correct?
Again, if you're talking to them and they're not in withdrawal, like and you just give them Suboxone, we're going to precipitate withdrawal. So, um, oh, how long? So, Michelle, do you mean like could you clarify and you can unmute if you'd like? Are you talking about the first patient or the kratom patient and like the long-term treatment duration? Is that what you're asking?
Yeah, I'm talking about the kratom patient. And
Okay.
I'm not familiar with this. I work at the VA, but we see a lot of this. And
Mhm.
there's something, if for, at least for me, if you've never used Suboxone, it seems like a pretty drastic measure. And so there's a lot of uncertainty about how to prescribe it and how long and things like
Okay.
that.
Yeah. No, so that's a great question, and I think with kratom or with any other opioids, it should always be individualized to the patient. There is some residual stigma, I would say, that Suboxone should only be used for a limited time. There used to be like some insurance restrictions. I believe Nebraska Medicaid used to. That you only have like you start a clock and like you only have 12 months and then you need to be off this. And I always thought that was really stupid because say somebody has diabetes, it wouldn't be like, well, you only have 12 months of insulin. It's like that's not how this works. That's not how any of this works. I I think that you'd want to assess somebody, and again, with kratom or with other opioids, I think that the decision of is it drastic to start it, and again, I can get into some of this if I can pull up my slides up. But kratom has the potential for a host of complications. It not only is active on opioid receptors, it has some stimulant-like effects. It has some like other psychoactive effects where it can cause all kinds of things. It costs a lot of money, and you do go into withdrawal pretty badly from it, and it's harder to control. It's again, it's a lot less like pure. There's a lot of, like I said, off-target pharmacologic effects, and the ever-present danger is if somebody is like, I feel terrible, and my brain stem, like the same way my brain is going to like force me to breathe, my brain is going to try to force me to stop feeling like this. Like it is bad. So the danger is that somebody's going to go get fentanyl or OxyContin, or whatever they think is, a prescription drug, which is probably still fentanyl. And it might also be a nitazene. It might have xylazine in it. Again, it is a dangerous time to be buying opioids on the street. And even if people think they're buying meth, it may still be opioids because they're super, super habit forming. And drug dealers know this, and they want to extract money from the bodies of the patients they victimize. I think that it may be drastic to put somebody on Suboxone. I mean, when the alternative is maybe they overdose and die, which is very, very plausible. Yeah, John.
Yeah, I'm, Michelle, I'm going to ask if you were asking about the use of buprenorphine, um, specifically with respect to kratom or overall with respect to VA patients. And I am going to push back fairly severely about the idea that that's drastic or that is should be stigmatizing or something I completely disagree, and I'll talk about that in my part of this presentation. But I would say that from a data standpoint, most of our data shows that um, more often than not, longer term prescribing is safer than not. Patients do better with respect to whatever you're using the buprenorphine for, whether it be pain or OUD or kratom in the case like this, and that that sort of vocalized stigma is a problem, I think, in this area, and one we want to overcome. And the last thing I'll say is I would believe buprenorphine to be a first line treatment even for VA patients if we're going to be treating chronic pain rather than the kind of medications that are currently being used. And I'll kind of get into that. But I
Okay.
using
Thank
the
you.
term Suboxone, using the term, that's the negative side of the data the waiver that was out there, and we've stigmatized a drug that can be very effective. Last thing I'll say is, how long do you give antidepressants if someone has depression, right? Single episode, maybe a few months. Second episode, 6 to 12 months. A third episode, a lifetime. I would think buprenorphine is a similar kind of an answer.
Okay, thank you. I really wasn't pushing back on using it, but for people who don't prescribe this, is it best to send them to someone who does?
No, that's
As
why
far as
I'll,
I
I'll
mean,
show you.
because we've kind of gotten into a situation like this because people readily prescribed opioids
Yeah,
for long,
I'll
long
talk about
periods of
that.
time. So
That's a beautiful
that was my
segue.
question. I certainly wasn't pushing back on
Well,
using it. Thank you.
yeah, great question.
Yeah, no, Michelle, thank you for both making this more interactive and highlighting that, and having veteran family that's I'm passionate about this, and I know veterans have a unique set of experiences and a very high pretest probability of having had trauma, and like higher rates of substance use as well as being marginalized in their own ways, and that so. This paper about kratom dependence actually specifically focuses on veterans, and yeah, I would echo John. Uh, Again, individualize it, but how long do you treat them? As long as they need it, and reassess and make sure they're benefiting. And if they are doing well and you can wean, some patients will come off fairly quickly. Others will find like, no, I do better on this long term. And again, is my patient doing well? That's always what you come back to, and you do whatever's right for them. And I think that referring out is, I mean, it can lead to the patient kind of being a hot potato, where they and just get bounced around. And the patient may readily perceive nobody wants to take care of me. That can come across to them, which is its own kind of stigma. And again, a lot of this is not the medical complexity, it is the stigma around it. The way that we used to have this special waiver where you had to go get a scarlet S for Suboxone tattooed on your chest. Even though you could, and some people did, write tons of Percocet and OxyContin, and it's like that was backwards. It should have been the other way around. The way the United States said this was really stupid, in my personal opinion. The views reflected in this rant do not reflect those of the NMA or Will Schmeckley. This is all me. So, and I think that again, for veterans in particular, that brings up another case that I wasn't planning on talking about, but I will gladly talk about. So, again, this was one of the resources I looked at for my non-veteran patient who came in on kratom. And again, the people can have a rougher go. The patient of mine who was not in withdrawal, we set up a planned home induction where I gave them the cow sheet. They rotated over in the comfort of their home. I actually saw them back. Their pain is better. Their NPT, their arms doing better. They're back to their crafting, which is very important to them. We got them hooked up with our psychiatrist, and we're getting their ADD managed, and we're getting their like HIV, Hep C screenings and stuff. I just saw them yesterday. They're doing really good. There was another patient who was using, I think, 200 grams a day of 7-OH, which is a metric F ton, I believe is the technical term. That person was in withdrawal, and so like I did a cows with them in the office. They were in moderate withdrawal. I sent them a prescription and tried to start them, and they actually went back to the 7-OH because they were still withdrawing. So I wrote out an opioid taper basically with the grams of 7-OH instead of like grams of OxyContin, but I just had them decrease by like a small amount each week, and I'm seeing them back next month to go at it again. You can also use a patch microinduction. I can get into that, but I don't want to take time away from John and monopolize the whole hour. And I do want to talk about this other veteran patient that I had, just because again, I think that's a great thing to bring up. So, I saw a veteran who's about my age, who was getting care at the Omaha VA, had an injury in the past and had been on tramadol, and then had a new spine injury, got worked up, and in hindsight, what I think happened is that they had an underlying chronic pain and they were sensitive to opioids, so they were tolerant to them. And I think that they unfortunately had a neurosurgical target that was plausible, where I don't know that was ever what was causing their pain because they wound up having injections and then a spine surgery that totally didn't help. And so the formal diagnosis was like failed back surgery syndrome. I mean, I think they just happened to have their MRI looked a little funky, and everybody blamed that. But they also have PTSD. They have been on some benzos to sleep from their psychiatrist. And I think it was really just kind of unlucky that their MRI, gave people something to hang their hat on. But in hindsight, that clearly didn't work. Uh, this patient had been in, and this patient's also a woman. So there's that angle of it too, that she's marginalized, and women veterans have even more stuff that they've often been through than male veterans. So, which I think sucks. So, she had been in the VA's ER constantly, and had been on escalated up to hydrocodone, but was like the surgical team wanted to wash their hands of her. The interdisciplinary pain team was like, not very helpful, to be blunt. Her primary was like, "Oh, you're on a benzo," and like, this is a surgical thing, but it was basically like the surgeons were like, no, she's post-surgery. And then primary was like, no, but she had surgery. And then the pain team was like, I don't know. Her psychiatrist didn't weigh in on this at all. And so like actually one of my former attendings uh, wrote a very frustrated note of like basically saying, would somebody please freaking own this because this patient is in the ER constantly and her quality of life sucks. She's missing work. She works, she does have a job, doesn't drive, so that's a barrier for her. And was constantly vomiting and having headaches and having uncontrolled pain, which can all be what withdrawal shows up with. You have GI symptoms, and like if you already have existing pain, when you're in withdrawal, the volume on that just gets turned way up. And so basically, and nobody wants to touch her. And then she goes and sees one of my PAs, and they do like a muscle relaxant, which she wants. She's getting some Toradol shots, but she's like breaking down in tears because she feels like nobody's helping her. And the ER is basically managing her opioids, which is like bad use of resources and like the worst possible way to do that. And then because I'm old and lived through the OxyContin shenanigans, when yes, people did prescribe way too much and way too carelessly, she gets shunted over to me. And so then I said, I'm reading through hundreds of pages of VA notes, including some that say that they don't think that she should be on opioids. And so I'm trying to come up with a plan. So, uh, if you had this person coming to see you, Michelle, it sounds like theoretically she could have, in looking at it and checking the PDMP, like there's not doctor shopping. She keeps going in to the people she's supposed to and asking for help and basically not really getting it. And she's averaging about 40 milligrams of hydrocodone a day. So can somebody in the chat say is 40 milligrams a day? How much morphine is that? Is that like low, medium, or high?
Low, but it's
Very high.
inappropriate.
John, you're killing me here. And I should specify, and somebody who's not one of the faculty. But okay, so yeah, it is low. It's fairly low. About under 50 is considered low, and then 50 to 90 we usually think of in primary care as moderate. Over 90 is high, but the highest I've seen has been hundreds of milligrams. And again, as long as somebody doesn't go from zero to that fast, that would, again, people can get to like hundreds or even like one person on methadone was up to about 1,000 morphine equivalents. They're stable. So that's not great though. So for this person, I prepared a plan to recommend buprenorphine and sat down with her and just tried to listen to her. But I was like, this looks not great, and she's on benzos, which benzos and opioids together. Like I've had a lot of patients on combos over the years, back when that was inappropriately prescribed left and right, and then they get fired or their pain clinic would get shut down by the DEA, and they'd come to us. So, but I don't love that. However, in talking with her, this veteran is focused on her job. She was eagerly awaiting a second opinion with a non-VA local anesthesiologist who she has since seen. Again, she's not doctor shopping, and she is wanting to stay on orphenadrine, her muscle relaxant, and wants to try to stay active. And So I discussed buprenorphine with her, but she actually asked if she could, just maintain her opioid dose, and I was like, all right, let's see how this goes. And So I wrote for hydrocodone for her, had a short follow-up, and she has not been back in the ER once since then. She's seen the local anesthesiologist. She is holding the benzo, it was triazolam or yeah, something. It was one of the sleeper ones, and I asked her, please don't do that, and she's been doing that. And we're talking about trying to help her wean down. Now, I'm still uh, discussing buprenorphine as an option for her based on my learning in this setting. But again, it's been like night and day. Like she was in the ER 7 times in 1 month, I think, she needed somebody to like just grab hold of this and again, she is, in my view, using these opioids to engage in her life and go to work, not getting doped up to escape from her problems. She's still seeing her therapist as well. So again, I think that there's a lot of yellow flags here, but again, I'm cautiously holding the course with that. And again, she highlighted that being listened to and not being treated like a hot potato or like everybody wants to just get her the heck out of there mattered to her. And I'm like, that, well, it's a low bar to clear, and I wish that she didn't have to see like 9 people for that to happen. But there we are. So, uh,
Alex, Alex, would you be willing to let me use that as a jumping off part for my part of this discussion? Because I got
it's
some
almost
data.
like we planned this.
I, yeah, I've got some data that I think might inform recommendations on that. If you think we can start from there, because
Yeah, please do. Yeah, it's actually about a half hour, so I think we have perfect timing.
all right, so that's a great case and one that we see all the time, and I think one that is a very good case that can be managed in a primary care setting with a little less stigmatization. I'm going to see if I can actually share slides. Let's see if I can figure this out while I'm talking. But here's see if I can get this. Hold on. So let's talk about the data on that because I think the data should be a big part of this. And tell me if these actually show up as they should. Um, I know it's not a PowerPoint yet, but here's what's interesting about this is now post-laminectomy syndrome, right? This person's had a surgery that was either unhelpful or not the thing to do, right? And um, and what do we know about this? Are you seeing my slides? What we
Yeah,
know,
we're seeing your
what we
slides,
know
John.
about low back pain, whether it's had surgery or not, if it's managed with opioids versus if it's not, and this is a meta-analysis, we looked at, there was a 500 unique studies demonstrated the same finding. It came out in 2012. That's 15 years ago. This, this meta-analysis showed us that if we manage chronic low back pain with or without prior surgery with opioids, we do 30% worse with respect to pain and function than if we didn't do anything at all for the patients. Okay. So using opioids for chronic low back pain will always fail for reasons that have to do with physiology and not stigma, not really not abuse or misuse. It doesn't work. So when we have an individual like that, and you're exactly right in your case, that's a low risk dosing of 40 milligrams of hydrocodone or more MME a day, but it won't work. And at some point in time, you're going to find yourself in a problem situation. And here's the why of that. Opioids are unquestionably effective at the time of an acute injury or when we've got nociceptive pain. That is, the problem is related in acute or subacute setting to a tissue damage. All right. Even if that tissue is nerve related, like an acute shingles, will respond relatively effectively to opioids for a while. Okay. The problem is that's not when we prescribe opioids. When do we prescribe opioids? We tend to prescribe them when we don't know what's going on, when it's widespread pain over time. And the interesting thing, we talk about nociplastic pain, we talk about central pain states. All pain eventually becomes nociplastic. All right. The central nervous system is smart. It's way smarter than we think. Even if somebody simply has arthritis of the knee, there's a lot of demonstrated effect that shows that treatment for nociplastic pain in individuals who can't have knee replacement surgery, that gets better if we use the treatments that are only working on the central nervous system. That's just how the body works. So, so when we're kind of artificially getting into this conversation about, well, when do we use buprenorphine or when do we use hydrocodone or is it risk or are they shopping or why are they getting fired and all that other stuff? What we're really doing is we're kicking the can down the road, and we're finding out that we're just not going to be successful in the long run if we're kind of doing that. And I'm going to show you something about this. I'm going to go right by my case studies, and I'm going to show you data that I think supports this. Again, these are oftentimes studies. These are individuals who are on opioids for the same kind of condition that Alex is talking about that do not have opioid use disorder. And these individuals are not on 40 MME, they're on 1,000 MME. This is an older study. They're on 200 to 1,300, a mean morphine equivalent of 500 milligrams of hydrocodone, describing pain that's 7 out of 10. Doing poorly. What happens? They're switched into buprenorphine, and their QOL goes up, all the metrics of functionality go up, and their pain is reduced by half. These are individuals who do not have a use disorder associated with their use. This means that buprenorphine is more effective than Schedule II opioids for chronic pain. All right. And not only that, but from a standpoint of what patients prefer, when we talk about analgesic efficacy, what patients prefer more than 90% of the time, it's really 95% of the time, they prefer the pain relief and the feeling they get on buprenorphine than on any other opioid they were using in the past. And it shows the same magnitude of effect at every MME range. So we were talking here about that individual that was at less than 90 MME. We're not worried really about the high dose. We're not worried that that's really going to be an overdose situation, but their pain was excessive and they were going to the ER. Everyone was kicking them down the road. And how come? Because they didn't understand that buprenorphine would be more effective, safer, easier to titrate, and most importantly, sustainably effective. All right. This is getting away from the idea of buprenorphine as a medicine for opioid use disorder. It is unquestionably superior, and I would say should be first line treatment. We're talking before you look at the data on muscle relaxants. We should not be using those. We should not be using opioids for more than 3 months or at most 6 months for chronic pain. It just doesn't work. Okay. And it's easier to convert than we think. And I think what's very clear on these studies is that the sooner we switch people over, the easier it is to translate them into something effective. And now all the other stuff sort of melts away because all of those aberrant behaviors, going to the ER, getting fired by bad pain doctors, going bouncing in, using more of the medicine and what have you, just shows that nobody's providing them what they need. And I think it's a little bit, we should think of it a little bit like patients with ADHD who start misusing medications when they're in their teens until they finally find a stimulant and now they get hooked on methamphetamines or cocaine, right? They're trying to modulate their central nervous system and they're not able to do so. So let me give you a couple of cases, and when you could kind of feel I jumped into the chat as fast as I could when Michelle brought up that patient, because I would say, I understand that now the VA has kind of a we don't use opioids policy, and I get that, but a lot of patients are on opioids. If you can switch them into a rational dose of buprenorphine and wipe out of your mind that this is for a use disorder, you're going to make a lot of people very effectively comfortable and sustainably so without the need for stuff that doesn't work. Because I would probably be willing to bet that whatever back surgery that your patient had, Alex, wasn't even really intended to make back pain better, but they saw the MRI findings. So they're like, well, we could probably make part of this better. And there was just a misunderstanding right from the get-go about what was going to be accomplished. Let me show you another case. And this is an individual kind of similar, 75-year-old farmer who's got acute radiculopathy and has long-term degenerative changes, also has a history of multiple myeloma, which I think gets right in the way of what's going on with the treatment. He's got ischemic heart disease, so much so that he was recently given a stent. Right after he got a stent, he got an acute radiculopathy, got an MRI before he came to us, and we see a disc, we see foraminal stenosis. There is something that's treatable and needs to be treated, but cannot because nobody can take him off his Plavix for another 8 months. He is therefore placed on increasing doses of medications. He's gone from hydrocodone daily to now fentanyl that's gone up to 100 micrograms per hour. He's given 4 Percocet a day by his PCP and tizanidine. He also has prior history of lorazepam for an anxiety disorder, and they're treating him. He's getting less and less successful, and he's got the multiple myeloma. So you see in the charts, people are saying, well, this guy has cancer. He's got acute radiculopathy. We can't operate on it because of his blood thinners. So we're stuck. All we can do is go up on the medicine. So I present this patient, and I think it's kind of similar to the patient you were talking about, Alex. Where are people? What would people say? How could we proceed from a primary care standpoint? How could we proceed to make this person feel better over the intervening 8 to 10 months before we can do something definitive? Any ideas?
John, do you want me to jump in?
Absolutely. Yeah,
Since I
absolutely.
just yelled at you for doing that as one of the other faculty, I suppose it's at least funny that I do it. I mean, I think, clearly you've been setting us up to look at, buprenorphine, and that partial agonist doesn't mean partial relief. I think a big thing for me is that buprenorphine has the safety advantage where with the ongoing benzo use, if that can't be adjusted, and in a 70, I've got a lot of 75-ish people coming from Mexico that are on inappropriately prescribed clonazepam and stuff, where I'm just like, great, so you've been on this since before I was born, and we're kind of stuck. But yeah, I see John jumped in looking at buprenorphine. Yeah, I think the question would be how, like, again, how much do we need to wean, or can we try to roll over? This is higher dose opioid, and with a transition, that's a little bit more concerning. So in this case, I'm not mad that this person is seeing you as a pain expert. But I
Right.
wonder if we could maybe use a buprenorphine patch to do a microinduction, and then just start taking Suboxone, and then just stop the fentanyl when they're already loaded with buprenorphine. But I'm eager to hear what you think about this.
So that's a great thought. So what you're thinking of is a microdose induction, right? And
Yes.
I've got some slides about but that is, I would say that's the right idea and the wrong execution for a couple reasons. One, uh, the highest patch we can get is 20 micrograms an hour. That's 480 micrograms a day. 480 micrograms a day that's going to be kind of an expensive way to start a microdose induction that isn't going to get us where we need to go. And it's a numbers thing, but that's exactly and this is exactly what we did here, and with some success. And what Alex is talking about here is we've got pretty high doses of opioids. I don't even have the calculation on my head, but we've got a long-acting fentanyl, which is the bigger problem, and the Percocet, the oxycodone, which is short-acting. What we did is a microdose induction. I'm going to go through and I'll show you how we did this, but let me see if I can find a good, sorry, here. So we did what's called a microdose induction. We've talked about that before. And what that does is it takes advantage of the pharmacology of buprenorphine in an effort to replace the opioids receptors with buprenorphine while gradually taking out the legacy opioids. And you can do this without the need for withdrawal because the patient will perceive withdrawal as an increase in pain, like we've talked about. And so what we did on this case is the first thing I had him do was take all of his fentanyl off and got rid of the 100 micrograms of fentanyl, which gives us about 12 hours of residual effect. Then I prescribed for him more of the short-acting oxycodone. He had been taking, as you saw, 4 to 6 a day, and I said, you may need 8 or 9 a day to take over for that fentanyl while we're starting this induction. And we started the induction just like this, and it's really cost effective. I want to, and Michelle, this is available in the VA. Basically, what we do is we take buprenorphine And you'll notice it's a quarter pill or a quarter film, which is the 2 milligram dosing of that. So what we're starting this individual on is 500 micrograms of buprenorphine once or twice a day. And we really go to twice a day. And remember, when you're using even high doses of buprenorphine, a lot of the receptors are still empty. So there's plenty of places where that buprenorphine can fit into the receptor without necessarily removing the legacy opioids, which is what will act like what will give them withdrawal. So in this case, what we did is we put them on 1 milligram a day. That's 0.5 milligrams or a quarter pill or a quarter film twice a day for a couple of days. And then we went to 0.5 milligrams 3 times a day, which is 1.5 milligrams for another 48 hours. Half-life of buprenorphine being 38 hours, steady state not being reached for 140 to 150 hours. You see, we're building that up very slowly. And at no point do we tell him to stop his oxycodone. Take the oxycodone if you feel like you need it. And we say if you feel like you're having more pain, or if you're having anxiety, or if you're having anything that can even be opioid withdrawal like, just take your oxycodone and build this up until we get to about 3 milligrams a day. And we kind of somewhere between somewhere between 2 and 4 milligrams a day will be equivalent from an analgesic efficacy standpoint to his prior fentanyl/oxycodone combination. So when this guy gets to 3 milligrams a day, we say, if you're having any withdrawal or if you're having an increase in pain, once you get to 3 milligrams, so that's about day 7 or 8, we'd like you to think about taking more of the buprenorphine rather than reaching for your oxycodone. If you feel like you can't do it, do what you want, but we're going to visit again at the end of the week and we're going to see how to sneak that up. This really works on almost every patient with one main caveat. You'll either go too fast or too slow, and that will always scare a patient if we're not just upfront about it. And what we have to say to these patients is, if you start to feel like you're having a reaction that you feel anxious, you feel, diarrhea or all those withdrawal-like things, jittery, muscle cramps, you're going too slow or we're going too slow. Conversely, if you start to feel nauseated or you start to feel drowsy, we're maybe going a little fast. But as long as we allow them to kind of gradually go up, we don't force them into withdrawal, somewhere between day 4 and day 10, we're going to get somebody saying, you know what? I forgot to take my oxycodone. And oh, incidentally, I'm feeling better. What do you mean you're feeling better? My pain is going away. And then the person next to them says, and they also just seem clearer to us. Really, what we're doing is we're just replacing those drugs that are not working on the receptor the way we want with one that does a better job. And the stability of it that puts it with that half-life makes them just feel less medicated, managed than before. It's really a smooth trick, and it works especially well for patients with pain that do not have a use disorder. Okay? They feel the pain relief with this very effectively, and it is almost 95% of the time universally way better analgesic efficacy than fentanyl oxycodone combination that had been gradually titrated over time. So I make this point because we just live in this space where we think of Suboxone, Suboxone, Suboxone. We don't think of buprenorphine as a medication that's therapeutic outside of use disorder. And if we can just internalize these microdose inductions, we can scrape away the remaining stigma on this, because the other part that's interesting is if this individual gets to 4 milligrams a day and he says, I don't feel good yet, I still feel bad. Now we're going to go up into higher doses above 4 milligrams a day. And as we've learned over the last few years, 4 milligrams a day is the baseline where we are, where we get protection from relapse if somebody has use disorder. So if people have the dependency, that the opioid dependency physiology really going on, then they're going to feel better at 4 milligrams and above. And so sometimes we end up kind of almost accidentally saying to the patient, oh, you're not comfortable on 3 milligrams a day, and we go to 7, 8, 10 milligrams a day. And afterwards we're like, maybe you did have a little more opioid dependence than we recognize. How do you feel about that? Well, once they're feeling better, their pain's better, and they didn't have to go through withdrawal, we've really de-escalated any of that stigma in their mind, like, oh my gosh, what are you telling me? I was an addict? No, you just had a different physiology going on there. And it's really quite simple to do. And the other part about this that's just going to amaze people when they first see this is this medication then works in a continual fashion at the same dose. When I see this individual in 6 months or 18 months or 24 months, they're going to be on the same 2 or 2.5 milligrams a day of buprenorphine that they were on when we first started them. They're not on this ladder of escalation that the other opioids give us. And that's very satisfying because they just come in, they say, I'm doing great, I'm back to work, I still have a little bit of pain, but we're managing it with the other things. And I don't need an increase in my medicine. I didn't run out early. I da 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 da. And so getting comfortable with this is a real tool in almost any environment. How does that feel to people? I want people to
I
challenge
just
me
want
on that.
to comment
Yeah.
because certainly I feel like I misrepresented the VA. This
Yeah,
is
I
a
know you did. No,
personal
you just said something. We understand.
knowledge deficit on my part, not the VA. And I work for the Minneapolis VA, so
Yeah. Yeah, no.
and I work in neurosurgery. So let me clarify 2 things. Number one, any surgeon I've ever worked with, and I've worked with neurosurgery for 17 years, will clearly state to the patient, this isn't going to help your back pain, right? It's going to help radicular symptoms, but it's not something for your back pain. Might get better, but
Yeah.
doubtful.
Yeah,
So,
decompression or something.
so
Yeah,
I
exactly.
I just want to be very clear that this is not a VA thing. As Alex said, our VA patients are suffering from pain for a number of reasons, and it's a multidisciplinary approach. Yes, do some people fall through the cracks and don't end up getting the care they want? Yes, but we see that equal on the private sector. So
Miss,
I just want to be clear that this is
on background,
a
since you don't know me,
personal education thing on my part, not the VA.
it's not, yes, that's a great point. I'll tell you, those studies I showed you that demonstrated the efficacy of this came from the VA. The VA has led the world in understanding what we're talking about. You're exactly right on that. And do not feel judged on that. And the other part about this, and um, uh, I would make the argument, one of the effective tricks, and I'm sure you guys have surgeons who do this as well, a very good way to help people do well perioperatively is to make this translation before you operate on them. Or I'm an interventional pain guy, so if I'm going to do something for pain, I think it's important to do this first before we do any of the interventional things that can make back, neck, joint pain better, because that amplified pain that comes on with that nociplasticity, whether it's a knee arthritis that needs a TKA or a base vertebral nerve ablation or a fusion or whatever, if we shut down the nociplastic physiology first, then when they have the procedure and we address the remaining nociceptive pain, that is the structural pain, it goes way better. And this is just what we need to get comfortable with as a medical group. And I would say it's not the private world and it's not even insurance, and it's not the VA or the what happened with this is I believe that it was the stigma related to the data waiver in 2000 whatever that said, well, you have to have a special license to write for buprenorphine. We were using buprenorphine effectively before that for pain, and we took it away because now it's this terrible drug for a terrible disease, neither of which are true, and now people lost their ability to use this. So I understand your point that it's absolutely not institutional, other than we got worried about this medication. Thank you.
Yeah, thank you, Michelle. Hey, a couple questions for you, John. First question, do you adjust the general protocol for older adults?
Well, um, yes. I would say the best way to do it is to adjust it for a lot of different reasons. On older adults, a little bit, but remember this: buprenorphine has a really, really good therapeutic index. That's because you never really get to a point of respiratory suppression. You can get nausea pretty quickly if you go too fast. You can get drowsiness, at least transiently, like you would with any opioid if you went too fast. But yes, we adjust the dose. And an interesting point, I was kind of impugning the transdermal buprenorphine, but a 5 microgram patch of Butrans, which is the lowest dose that you can get commercially available, is the equivalent of 2 to 4 hydrocodone a day, analgesic, right? And sometimes that's too much for individuals, but um, but usually not. Even elderly individuals, and we've we've had people on generic buprenorphine, 0.5 milligrams, and we can adjust that where they take it a quarter of a film every other day, every 48 hours, and they stabilize down to the same low dose of buprenorphine that the patch would be. So yes, you can adjust that. And I think the key on buprenorphine is that you do have to titrate to effect, understanding what's going on, and you have to get a little bit used to it. It does take a little bit of time, but it's not as hard as we've been led to believe. Very good question.
Thank you. And then one more question for you, John. What is the max effective daily dose of buprenorphine?
Well, what are we treating? And I as a rough
I can elaborate a little bit.
yeah,
This is Denise. Sorry. So I have treat some patients with opioid use disorder,
yeah.
and they request higher doses, and I've been taught to stick to 24 as the max a day. And I just wanted to know your thoughts on that.
Well, Todd, I'm going to make Todd step in, but 32 in some individuals is a little bit better, and
Okay.
it's an insurance thing. But Todd, you have better answer than that.
Yeah. So, I hate to go to it depends, but part of it is their metabolic machinery. What's their, uh, are they, a normal metabolizer? Are they a slow metabolizer? Are they a rapid metabolizer? But in general, most would say it's in it came out initially, and this goes back to when I first started prescribing it back in 2003. It came out initially as 32 milligrams, overregulated and so on and so forth. Then it backed off to 24. And now I would just say a general rule of thumb is within the range of 24 to 32. And sometimes it's even most effective for dividing the dose up as opposed to giving it all at once.
Okay. Thank you.
Awesome.
All
This PowerPoint has it has more microdosing protocols, but I want to make one more plug. All of this information is going to be incorporated into the Nebraska pain guidance document that we've been working on with this group and through HHS. We have 2 chapters on buprenorphine that are being added to that. The first chapter being buprenorphine for opioid use disorder, like Alex was talking about with and kratom. And the second chapter is how to use buprenorphine as a chronic pain treatment in the absence of use disorder. So all those questions you have, we hope are answered then. We've finished that chapter and it's in the process of being reviewed by all the relevant boards. But look for that in the Nebraska Pain Guidance document in the next couple of months, hopefully, and it'll be a much more complete than my PowerPoint here. And there, I've got more protocols here. I think everyone will want to individualize it over time, but the key here is going slow, letting the buprenorphine grab into the receptors. It will hold on, it's more tightly bound, and it has longer half-life. The slower you go, the smoother it is in many individuals. And so you're sending off a prescription for oxycodone. At the same time, you're sending off a microdose induction of buprenorphine, and we just have to get over that. That's how we should do it, and it makes a patient accept it, and then it goes very well. And it does require some communication with the pharmacy from time to time, but when you do it that way, patients they just don't feel stigmatized. All you have to say is, "I'll make your pain better. I have a better medication. Stick with me. We'll find the right dose," and they'll walk through that with you very successfully.
Great, great. I know if folks need to run, feel
Yeah.
free. We can finish up here. A reminder, I just wanted to remind John and Alex, would you guys be able to send me your slides and those materials that you had as well, Alex? We had some requests for those in the chat, and I can send those out in an email later this morning. Great.
I think I did send you those. Did you get those, Will?
Oh,
I just did it this
gosh.
morning. If I didn't, let me know.
Yeah, I
All right, I'll resend.
don't think it came through for some, yeah, maybe try again. Sorry.
Okay,
Yeah.
my bad.
Um, no, that's okay.
Your error.
Um, let's see. Oh, so yeah, there is a link in the chat if you want to grab that, claim that certificate. And again, I'll email that out after you complete that quick survey. I'll also be emailing that link out here within the next hour or two this morning. We did have one quick question that we can try to get to. Do you have trouble with insurance companies declining to pay for buprenorphine?
Um, well, yeah. So the reason we have to go through all these machinations with cutting up that buprenorphine is, Belbuca is available, which is a branded version of buprenorphine that ranges from 75 micrograms twice a day up to 900 micrograms, or essentially a milligram twice a day. And it's very expensive, unless, you can always, private can always get coupons and what have you. So yes, but let me contextualize this. Oxycodone, Oxycontin, morphine ER will cost the patient $5 to $8 a day, right? That buprenorphine, 2 milligrams that we divide into a quarter, so they might be taking 30 of these a month, they might be taking 15, they might be taking 45. You can get that with GoodRx for $65 for a month. Okay. It is very cost effective, and cost doesn't get in the way of this with respect to what we're replacing with. It is cheaper than pregabalin and gabapentin and duloxetine and all those others if you're thoughtful about how to do that. And you really kind of have to walk people through saying, well, we're going to cut this pill in half or even a quarter, and that's been to us a real saver, because now you don't have any reason that you cannot do it. Great question, by the way.
Yeah, great. Well, thanks everybody. Thanks John and Alex for leading the way today. Great job as always. We'll be back 2 weeks from today. I think we've got Mary and Stephanie lined up to talk about children and adolescents and substance use. So hope to see everyone back then, and have a great Friday. Thank you.